Hello everyone, this is Assistant Professor Ali Abdul Karim. Today's lecture is Splinting Mobile Teeth, Rationality, Types, and Decision Making. Hypermobility of teeth is a common issue following the loss of tooth supporting structures, which may be due to various etiological factors, such as periodontitis and occlusal trauma, in which increased tooth mobility adversely affects the function, aesthetic, and patient's comfort. Clinical management of periodontally compromised teeth with advanced mobility remains a challenge to the clinicians. Hence, splints are being used to overcome these problems. Splinting teeth to each other allows distribution of force from mobile teeth to their immobile neighbors, thereby gaining support from stronger teeth. Literature indicates that the main reason for periodontal splinting are primary and secondary occlusal trauma and progressive tooth mobility, migration, drifting due to periodontal and/or periapical causes. According to Miller, mobility can be assessed clinically via the following scale: 0, no mobility, score 1. It is a horizontal mobility not exceeding 1 millimeter. Score 2, mobility in horizontal direction more than 1 millimeter in buccolingual direction, while score 3 is mobility exceeding 1 millimeter in buccolingual direction combined with a vertical component. For selecting a proper treatment modality, first of all, the reason for increased tooth mobility must be recognized. Whether the cause is a widened periodontal ligament due to periodontal disease or trauma from occlusion, reduced height of the supporting tissues, or a combination of these factors. An increase in tooth mobility because of widened periodontal ligament may be reduced by occlusal adjustment alone by eliminating the occlusal interferences. In case where occlusal adjustment will not reduce the tooth mobility, reduction of mobility can only be achieved by a splint. Splinting in such situations is only indicated if the mobility disturbs the patient's masticatory function or chewing comfort or aesthetics. If the increased tooth mobility is due to a combination of widened periodontal ligament and reduced periodontal support height without active periodontal disease, the occlusal adjustment may be sufficient to reduce the mobility to an acceptable degree. However, available evidence provides conflicting data. Therefore, it is very difficult for the clinician to decide whether to use splinting or not. What degree of mobility can be managed? Whether grade 3 mobility can be managed with splinting or extraction is the ultimate cure. When selecting a tooth for splinting, the following factors should be considered. First of all, the total periodontal membrane area of the abutment teeth must equal or exceed that of the tooth to be replaced. Also, the length of the periodontal membrane attachment of the abutment tooth should be at least 1/2 or 2/3 of that of its normal root attachment. Moreover, teeth with mobility or widened periodontal ligament should be avoided as abutment for splinting. Splinting is indicated in various situations, including restoring function, aesthetic, comfort, stabilizing teeth after orthodontic movement, or as adjunctive to periodontal treatment. Generally, splinting is contraindicated when the remaining teeth are not sufficient enough to provide support for the splint. In addition to in the presence of poor oral hygiene, high caries activity, and crowded or malaligned teeth. Dental splints are generally classified into three main types. The first one is short-term or temporary splint, which is used less than 6 months and may not be followed by additional splint therapy. It is used mainly during active periodontal treatment. The second type is the medium-term provisional splint, which is used for months up to several years. It is used for diagnostic purposes, usually lead to more permanent type of stabilization at the end of the therapy. While the third type, which is the long-term permanent splints, it maintains for a long-term stability and may be either removable or fixed type. Provisional splints, as the name indicates, they are designed to absorb occlusal forces and stabilize the teeth for a limited amount of time. They can be useful as adjunctive to many different types of treatment. They can be placed either externally or internally. Splinting makes oral hygiene procedure difficult. Therefore, to ensure the survival of the connected teeth, special attention must be given to instructing the patient about enhanced measures for oral hygiene after placement of the splint prosthesis. Effective personal plaque control, professional caries risk assessment, and periodontal maintenance are crucial to the survival of the splint and health of the splinted teeth. It was generally believed that mobile teeth may inhibit periodontal repair. However, current studies have shown otherwise. First of all, splinting of teeth will not prevent apical downgrowth of dental plaque. Splinting of mobile teeth before scaling and root planing not have any adjunctive effect on healing. Splinting not have any influence on bone and attachment level after osseous surgery. Splinting of mobile teeth not have any effect on mobility reduction after initial therapy. Attachment levels and bone levels were similar in splinted and non-splinted teeth following osseous surgery. Although current guidelines for the treatment of mobile teeth and traumatic injuries recommend the use of flexible splints, the specific definition of what is considered flexible versus rigid has not been clearly defined, leaving the clinician with a wide range of options for this critical factor. However, evidence from recent studies can be summarized as follows. First of all, direct composite splint significantly reduces tooth mobility. Nylon composite and wire composite splints are equally effective in reducing mobility. Nylon plus stainless steel or nickel titanium wire is a favorable choice for splinting and management of traumatized teeth. Sandblasting the stainless steel wire embedded in the composite resin enhances the strength of wire composite bond. Dental trauma is a common injury, especially in children. Avulsion is a serious injury that can cause damage to some or all of the dental and surrounding tissues. For avulsed teeth, type of splint doesn't have a significant effect on the type of healing. However, dental splinting is frequently needed following traumatic injuries to stabilize subluxated, luxated, avulsed, and root fractured tooth. The prognosis is mainly determined by the type of the injury. Duration of splinting should not exceed 10 days. Most of the evidence available are obtained from animal studies. In a study on rhesus monkeys to determine the effect of splinting on hyperocclusion, results showed that splinting of a tooth helps in redistributing the occlusal forces over a larger area. Also, it was observed that the areas of root bifurcation and trifurcation are more susceptible to excessive occlusal forces. In another study on monkeys as well, showed that rigid splinting of luxated teeth not improve the mechanical properties of periodontal ligament during healing. In general, occlusal adjustment reduces mobility by 20% when tooth mobility exceeding 0.2 millimeter. Finally, splinting mobile teeth act as adjunct to periodontal treatment and maintenance, and it is recommended. In summary, available evidence suggests periodontally compromised teeth with poor prognosis can also be retained for a longer time by using splints. Splinting is an adjunct in addition to cause-related therapy in the treatment of mobile teeth. Splinting itself will not eliminate the cause of tooth mobility. Role of splints and patient selection criteria require further investigation. Thank you for listening.